Doctor. Thank you so much for joining us. Why don't you tell us a bit about yourself and your qualifications?
My name is Victor Leung. I'm an infectious disease physician trained in Canada. Did my training at McGill University and certified in both infectious diseases and medical microbiology. I currently practice in Vancouver, British Columbia, and am a clinical associate professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia.
Why don't you tell us about monkeypox? Is it generally a fatal disease? When do patients, in your experience, need to be hospitalized?
So outside of the endemic countries in Central and West Africa, monkeypox has not been seen to this extent before. So this is the largest multi-country outbreak outside of the endemic countries by far. And so the information related to mortality and severity of the disease is still, I would say, unknown. Fortunately, with the outbreak so far, there have been no reported fatalities. I think that with our ability to case find and a significant, probably underestimation of the number of cases, I think the 1% mortality that was quoted outside of endemic countries, or approximately 3.6% mortality in the endemic countries with the Western clad, are going to be the upper bounds of what we expect to see with mortality. However, that does not take into the account the other consequences that can occur when we have widespread transmission of a emerging zoonotic virus.
What do you mean by that? Like secondary effects, like immunocompromise or other infections, I guess, or?
Yeah, so I think for the individual, there's going to be different impacts depending on the individual's level of immunity and whether they're immunocompromised and to what extent. But more so at a population level, when we think about what are the impacts of this going to be in terms of having a new virus be transmitted in places that this virus previously was not thought to be circulating. And this can have impact longer term, specifically on reverse zoonosis or spillover back into an animal reservoir. Now that's at this point still very speculative because we don't have knowledge of what the animal reservoir in nature is naturally. Based on some previous studies, there are certain animals that have been identified to have the virus, but we still don't know what the natural reservoir is.
So I guess the fear is that it circulates enough in the public, it'll find an animal to stay in somewhere in the wild, and then come back and reinfect us periodically in non-endemic countries. That's the big fear, I guess, eh?
I think that's one of them, or just ongoing propagation and ability for the virus to find a new host and establish itself in humans.
Okay, one thing is we've grown up, you and I, without smallpox ever being a factor in our lives. It was eradicated before we were born. How is monkeypox different from smallpox, from other orthopox viruses? Like what's distinctive about it?
So in terms of overall impact, I think the mortality of monkeypox is a lot less than with smallpox. The severity of illness is also less by inference. And with smallpox, because it is falls within the orthopox virus, like other orthopox viruses, those who have immunity to smallpox will have cross protection against other orthopox viruses. So the clinical presentation will also be different, and we can talk about some of those findings later. The diagnostic testing that's used in general as a first-line testing will be the same in most places, which if they start off with a orthopox virus PCR, that will be a generic result, and then subsequently to identify which type of orthopox virus in the laboratory would have testing implications. In terms of, I guess in terms of impact of transmission or transmissibility, it's also thought to have lower transmissibility compared to smallpox.
Well, that's fortunate, smallpox with such a high mortality rate. Hope, we have something that is much less contagious, much less virulent, hopefully. I understand that there's two different clades of monkeypox. So the West African and the Central African. And I guess we're relatively lucky that we have the West African one spreading versus the Central African, which is more deadly, I think, right?
It is associated and reported to have higher fatality rates, whether that's due to the virus intrinsic factors itself or just due to the circumstances and where people are affected and have access to care is I don't think is entirely clear. There are genetic differences in the genome that differentiate it, and also there's the spatial epidemiologic differences that we see in terms of where it's located. But I'm not aware that there are specific virulence factors that have been clearly identified to determine why one clade is more associated with higher mortality than the other.
So it could be factors where they're spreading, like the overall underlying health systems, a bunch of other factors that we don't know yet. Yeah. I guess this is the $1 million question when it came to SARS-CoV-2, but how does monkeypox spread?
So if we look back at some of the old ways of describing infectious diseases transmission and a lot of the accepted guidance now, we talk about the ways of protection as a measure to describe a mode of transmission. And we've all heard about the general terms that we use in healthcare as a precaution. And so there are standard precautions, contact, droplet, and airborne precautions. Now, I think that those are useful because they're simple, and it allows a healthcare worker to think what exactly they need if they see a certain syndrome or a disease. But I don't think it adequately describes the modes of transmission. So I think now, having looked at the literature a bit more and various people trying to better characterize modes of transmission, I think for monkeypox, we can think of it in several different ways. One of the modes of transmission is through direct skin-to-skin contact. And that skin-to-skin contact could be skin with mucous membrane contact or skin-to-skin contact where the skin is infected. And the infected skin could vary from a rash that can have fluid or pus in the lesions. It could also just have scabbing. And that's why, in terms of how long someone is infectious for, the general recommendation now is until the scabs have completely fallen off and that there is healthy layer of visible skin below that. So the other way of contact is directly with infectious bodily fluids. Now, we don't have a clear understanding of what all the different compartments of bodily fluids that could be infectious. We know that blood can have the virus based on detection through PCR. Urine can become PCR positive, or genetic material can be detected in the urine as well. Similarly, with saliva or swabs of mucous membrane sites that are infected. One of the things we didn't know before is whether vaginal fluid or seminal fluid can be infectious. A recent publication from a small case series of 4 patients in Italy, where they reported on the initial outbreak, has reported on semen having positive genetic material detected. What we don't know is whether that is a virus that can replicate or not, because it's just detecting based on PCR. Other ways for transmission include direct contact with inanimate surfaces, such as fomites, that may have been contaminated with the virus through different means. And that could either be through direct touch of an inanimate surface, if the skin is infected or has virus on it, or it can be through secretions, such as respiratory secretions. And those secretions can range in size before they deposit on these inanimate surfaces, such as large droplets, which will fall on these surfaces, or aerosols that linger in the air and eventually land on a surface, contaminating an inanimate object. And then a third way is direct deposition of infectious fluids on susceptible tissue. And that generally is thought to be mucous membranes. So for example, if there is direct impaction of a large respiratory droplet onto the mouth, eyes, or nose, that could be one of the routes of transmission, similar to how we described with SARS-CoV-2. Finally, there's also respiratory aerosols that can be inhaled. So we know that because it is detected in the upper respiratory tract, and when we talk about detection of positive virus at high viral loads, it could mean that when someone is speaking, coughing, sneezing, they can also expel high concentrations of aerosols that, if inhaled, can lead to infection. And finally, there's the case reports of maternal child transmission through a transplacental route, but that's still relatively or there's rare reports of that. So I think we have to think about transmission in all those modes. We do not know yet the relative importance of all of the modes of transmission. Classically, it's been thought that the most important mechanism is through the direct skin contact. However, I think that because this is still relatively new in terms of studying all the modes of transmission, we need to take the measures to protect healthcare workers in those settings. And I think Canada has done that. So as a precautionary basis, in Canada, when managing someone with suspected or confirmed monkeypox, it is recommended that the level of precautions used achieve both contact, droplet, and airborne precautions, but particularly important that the healthcare worker realize that that means the personal protective equipment will consist of respiratory protection in the form of an N95 respirator, eye protection in terms of goggles, and then the gown and glove for protecting the skin.
That's quite worrisome, especially the airborne component to it. One thing that I wonder is how hardy are the viral particles on surfaces? Like how, if I go into a swimming pool, or if someone goes to a swimming pool, how would the chlorine destroy it? That's a lot of patients are having questions like that. What would you say to that? Like how hardy were smallpox particles in the historical period?
So although we can separate the mode of transmission from infectivity, I think that there are some things that the mode of transmission can inform us, as well as what we've seen so far in the outbreak reports. Traditionally, from the outbreak reports from Nigeria or the DRC, or transmission outside of the endemic countries, there haven't been significant secondary chains of transmission. And so I think that is reassuring in that even with multiple cases that have been followed closely, traditionally the chains of transmission have been relatively short without further spread once identified. However, I think one of the areas where it is concerning is what we're seeing with the current outbreak is a high association of transmission through sexual activity. Now, sexual activity allows for all those modes of transmission to become relevant. And so the ability to transmit outside of that scenario, at least based on the current outbreak descriptions, suggests that the risk to the general population who aren't having those direct, very close proximity physical contact is low. We know from the disinfectant studies, at least there aren't very many studies looking at multiple surface testing to see how long a virus can survive, but it is a susceptible virus to standard disinfectants. So in the hospital, using our standard bleach solutions or hypochlorite solutions will be sufficient in inactivating the virus. There have been some laboratory studies how long it can last in a experimental aerosol setting. And I believe that they had in that study found that the virus could be replication competent up to 90 hours. Now, we have to take those studies as well as the surface transmission studies with some caveats, because we don't know how that is replicated in the real world based on exposure of the virus to, say, UV light or the natural ventilation settings. I think what we can say is that this is not a virus that is highly transmissible based on our current knowledge of the reproductive number.
That's reassuring to know that it's not as contagious as SARS-CoV-2, one of the most contagious viruses known. So you mentioned skin to skin transmission. Is it possible for someone to get it with intact skin, touching someone, touching a lesion or pus, or it has to be someone with a lesion or pus on the skin, or can intact skin contacting intact skin spread it?
So I think that we are not certain. However, some things that we can base on from our knowledge of other diseases that can be transmitted through the skin. In general, there would probably have to be microabrasions at the top levels of the layers of the skin for it to cause a disease. That's only one factor, however, because even if the skin is contaminated with the virus, although it may not cause disease at the site if the skin is intact, that can then transfer to other areas. For example, if the hands are contaminated and someone rubs their eye, I guess it'll be possible that then it gets into a site that's more susceptible for a site of inoculation for infection. From the animal studies, at least where people have had encounters directly with animals that are found to be infectious and then subsequently develop disease, one particular outbreak that has been described in 2003 in the United States was through the prairie dog zoonotic transmission. And in those cases, usually the site of inoculation is a site where there may have been an animal scratch or an animal bite versus just direct contact of the virus from the animal to intact skin, which likely will not result in disease.
Well, that's reassuring at least. I think in some people's minds that monkeypox has been wrongly labeled as entirely and as a sexually transmitted disease. But what you're telling us that it has multiple modes. It may be spreading through sexual contact in one community, but there's nothing stopping it from spreading from close contact in other settings.
Correct. I think what we're seeing now with the large numbers suggests a couple of things. That there were specific circumstances that allow this to transmit to multiple people. And now with mobility, travel increasing, that then, and also the long incubation period of this disease has probably set up the settings where this virus has had multiple spreading events and then with mobility transmitted to the multiple countries. That does not mean that it's going to be limited to sexual activity, because there will be secondary cases from similar to what we've seen before, possibly from healthcare worker or nosocomial transmission, that although that has still been thought to be rare, as well as secondary transmission within households, just because of living in close proximity, congregate settings. And those numbers do vary quite a bit in terms of what the secondary attack rate are in households based on the studies that have been published.
That's good to know. What precautions do you think that the public can take right now? Maybe we can split it in between cities that have ongoing outbreaks, like say London or Montreal, versus cities that have more limited spread. What advice would you give to the public? What do you think governments should be giving to the public now to keep themselves safe?
Yeah, that's a challenging one for me to answer. I think that from a public health system, one of the things that governments need to do is transparently communicate what their level of surveillance is. It is recommended by the World Health Organization that countries expand and be aggressive with the surveillance early on. And that means having case definitions that are widely known to the public and are broad enough to be able to capture potential cases. And that involves having both the public aware as well as healthcare workers aware of the case definitions in settings in which they should suspect it. After that, it means that the healthcare system also has to set up testing capacity. And unlike what we saw, hopefully, unlike what we saw with COVID, it won't be such a long lag time before diagnostics are more widely available. That doesn't mean that diagnostics should be overused or wasted. It just means that there should be a system in place to respond to performing diagnostic testing when there is a suspicion based on standardized case definitions. I think that by having those two things, this will set up a system where then you have adequate and timely public health follow-up with contact tracing, because we do have countermeasures that have been shown to be successful in the past in containing monkeypox outbreaks. And those countermeasures could vary from vaccinations to experimental treatments, as well as identifying contacts and appropriate management of these contacts. So I think if at the first step you have a government response or public health response that transparently will communicate those things and make people aware, then I think that people will take their adequate measures based on those, from what we know of the current routes of transmission and where transmission may be having place at higher levels of risk. I don't think that we need to escalate the level where the general public needs to do a lot of things differently. I think with experience with the pandemic now in the last 2 years, the public are aware of the various tools that are available. And I think if we can inform the public of what the risks that we know are, then people should take precautions. I think that the last part is, although we don't want to stigmatize the route of transmission as sexual transmission, it is also important, as argued by some experts in sexual health, that we need to recognize sex as a normal part of living. And what we need to do is raise awareness for people who are having sex and their sexual encounters, to be aware of when to seek medical attention if they have potential concerns of symptoms of this disease. Just like with any other sexually transmitted infection, where people may notice symptoms after a sexual encounter. And although this isn't strictly, is not classified as a sexually transmitted infection, because of the way we're seeing transmission now in some of the outbreaks, I think that there should be some attention and communication to that as well.
So I guess, like you mentioned, like people have, been taking precautions during the pandemic era. I suppose some of the protections from there may carry over, like to, preventing monkeypox. But like you mentioned, clear, transparent communication from government and is very important. And, outreach, and especially around, the modes of transmission, is very important. Thank you so much for elaborating on that.
Yeah, I think just making sure that people realize that the facts, that we know them now, and acknowledging the areas where we still don't know.
Oh, exactly. For individuals who are in contact with someone who has monkeypox, or they themselves have contracted monkeypox, what should they do? I'm sure they'll get, there's so few cases right now, they'll get instructions from their physicians, I suppose. But what is the period of isolation? What does that look like from the patient perspective right now? God forbid if you get it.
So firstly, I think in most places, the direct management in terms of public health implications and isolation will be dictated by the respective public health bodies. Currently, it's kind of the global consensus that I've seen is that for the period of infectivity, when you have someone who is infectious, they don't necessarily require hospitalization. Some countries will automatically have hospitalization because they consider it a high consequence infectious diseases. However, not everyone needs hospitalization, and in those who do not, measures are made to isolate in their home, or identification of a setting if a home is not available for isolation. And the duration of infectivity is thought to occur from the time of when symptoms first present, and that could be in the prodrome phase, when they may have fever or other non-specific symptoms, until all the lesions have normalized, meaning that if they scabbed, the scabs have fallen off, and that there is now skin that's intact underneath the lesions. That makes it challenging because not everyone will have the progression of lesions as classically described. So there may be some lesions that don't progress to a pox-like lesion that scabs over. So in the most recent cohort study published in the Lancet Infectious Diseases in, I think, late May, they describe 7 cases that were managed between 2018 and 2021, I think in the UK, in their high consequence infectious diseases airborne network. And in those cases, they continued to test people using different sample types: urine, throat swabs, nasal swabs, blood, lesion swabs. And what they find is a variation in when, at what time points the virus is at its peak or coming down to undetectable levels. What they found was the upper respiratory tract can have prolonged shedding of viral genetic material. We cannot conclude from that how that correlates or is associated with infectivity. So it brings into some of these additional questions. Well, even though we clinically think the person is non-infectious, what does it mean if we still detect genetic material? Do we need to, similar to SARS-2, have more studies on showing whether the virus is competent in replication or not? One of the other interesting findings from the study is in one of the cases, there was a rebound in detection of viral genetic material after things had resolved. And so the question is, are there reservoirs within the human host that can, that are maybe less or more protected from the immune system that can have viral persistence, such as the testicles, for example, where maybe the semen can have virus replication that's protected from the immune system. Now, those are all still speculative. We don't have evidence to know how long or how significant viral detection is in terms of infectivity. However, the general approach now is still based on a clinical assessment. And so I would imagine all patients, or expect that all patients who are under isolation have regular check-ins to assess the clinical progression to ensure that they have no symptoms and the skin findings are resolved before they should be considered non-infectious. That, of course, will have significant impacts on the individual, looking at the timeframes of how difficult it could be for someone to isolate, including ability to work, make an income, and have social activity. So I think those are some of the challenges now as the number of cases increase, the impact it has on individuals and then their networks.
Oh yeah, exactly. So it looks like a prolonged period, like weeks, like three weeks in some cases, and it was a struggle in many places to get any kind of support for time off work for COVID, which was a much shorter duration. Imagine, government will need to support people for 3-4 weeks. I think it looks like.
I think that would be an important aspect in the containment efforts or the elimination efforts.
I know this you might not be able to talk about it because of confidentiality, and only talk about it if you have permission from the patient, but have you treated any individuals with monkeypox? How did they present? What lessons can we give to other health professionals on spotting it, diagnostic testing, and then the treatment options?
So in British Columbia, the first case of Monkeypox diagnosis was announced yesterday by public health officials. I'm not in the position to provide more information around that case publicly. I can say that I was involved in the diagnosis of this individual. And so I'll go to the general aspects of this instead, which is what we should be thinking of and in what settings. We should be concerned about this on the differential diagnosis. So I know that you'll also have some sessions specifically at looking at the dermatologic manifestations. Classically, this disease presents initially with an invasive or prodrome phase where the virus is, or the immune system is starting to recognize the virus, and the patient will manifest symptoms. And that can range from 1 to 5 days with some features including fever, chills, headaches. People can develop sore throat, muscle aches. And so these general non-specific symptoms can be associated with many different types of diseases. So it makes it difficult to recognize at that point what's happening, as the differential diagnosis would be quite broad. This disease has been reported to be associated with lymphadenopathy, but sometimes the lymphadenopathy initially can be subtle. It may progress and present during the later stages of the invasive phase, or when the skin lesions start to manifest, and can occur at different locations, probably related to where the virus was first inoculated, or where the highest burden of virus was inoculated. After that 1 to 5 day period, then the rash phase begins. Typically, it's been described as starting off with macules. And even prior to that, people will have mucosal membrane lesions that could be in the mouth or in areas where there have been direct inoculation. And so those mucosal lesions in the mouth, for example, can present with soreness or just ulcers that are not recognized because they're not causing a problem. The macules on the skin then will progress to fluid-filled vesicles. And then the next stage can include these pox-like lesions that have pus. They can become umbilicated. Eventually, they will scab over and then fall off with underlying skin scarring, which can range or persist or resolve over a period of time. What's different in, I think, this outbreak, as described by the reports released in Eurosurveillance from countries such as Italy, Australia, the UK, and Portugal, based on their initial findings, as well as in the US reports, in the MMWR report, and some of the clinical presentations described in Quebec, is that the lesions, or that the presentation does not necessarily fall into that classical presentation. More commonly, what is being seen are lesions in the genital area that may be first seen in a primary practice clinic or a sexual health clinic. And these lesions can start in the genital area, on the penis, on the shaft, on the glands, or in the perianal area. Some lesions can be internal, and so they may not present with any external findings. And if there are internal lesions in the rectum, they can present as a proctitis syndrome. If the inoculation is through the respiratory or upper head and neck area, and people have direct contact with an infection through the mouth, then there's also describes quite significant pharyngitis in some individuals, swelling of the tonsils, for example. So I think that what we're seeing now, at least with what's reported so far, is a difference in the presentation than what was just classically described, with people having dense lesions on the face in the classical form, and the palms and soles. That may not be as prevalent now with this current outbreak.
And primarily because the initial contact was sexual in those cases. So like it's spreading, that site of inoculation was, rectal or penile or oral in those cases.
Oral spread, yeah, would be a consideration.
I'm looking at some of the case material that clinicians have been sharing in Canada. It looks like there's a lot more erythema swelling around the sites of these lesions. Like they're very much more painful than the average rash. Is that something that your colleagues have seen as well?
We haven't had any systematic presentation of all the cases. And so this is still just based on anecdotal presentations in communication with some clinicians who have been seeing one or more cases. So I think it's difficult to fully characterize what this disease will present as until we see that data accumulated and shared. I can say that from speaking to some individuals who have seen cases in Quebec, the lesions can be quite painful. I know that the one in Boston at the Mass General, the first case that was diagnosed in the US, did present with significant pain and needed admission because of that. But this was after a sort of prolonged period where there was no diagnosis.
How do you work up a case of monkeypox? Are you doing similar like a nasopharyngeal swab like you did for COVID? Do you do serum studies? Like, what exactly is your testing protocol? I'm sure it'll be different from location to location, but what are you guys doing right now?
It will be different based on the location of the disease and or the phase of the disease in terms of what is the most useful testing. But I think in general, people could refer to the WHO technical laboratory diagnostic recommendations or guidelines, and we are following those in British Columbia. Typically, you will want at minimum, if someone has skin lesions, swabs of those lesions in universal transport media or a dry swab. It would require unroofing of the lesions if they are presenting as vesicles or pustules, and then swabbing of the skin underneath that so that you get cellular material as well. The scab that's unroofed can also be tested with PCR. And because people may not present with lots of lesions or any lesions that can be swabbed easily, the prodrome phase, when people present with non-specific symptoms, you can also achieve diagnosis through other laboratory specimens, including a combination of oral pharyngeal swabs or throat swabs, nasal swabs or nasopharyngeal swabs, as well as whole blood in EDTA tubes so that can be sent all for PCR. We know that urine can also become positive, detectable by PCR at different stages of the illness. So taking a urine sample for PCR could also be done. What I would recommend is those who are unfamiliar with it, and also because it would require communication with the laboratory doing the testing, it's best to just speak with the laboratory ahead of time before collecting all the samples, making sure that you have them all labeled correctly, and then you have expedited or clear pathway to transport them to the laboratory that will be doing testing. So using that knowledge as a framework and then speaking to the laboratory where you're at.
What antiviral treatments exist for monkeypox? Is there anything you can give prophylactically? Is it given as a treatment? I know the vaccine can be given as a treatment, which is really interesting.
Yeah, so in terms of therapeutic countermeasures, there are antivirals that have been used. However, there isn't very much evidence supporting its use, in that there is not a significant number of people who have received these antivirals for monkeypox. In Canada, there is a medication that is Health Canada approved, but it is for emergency use settings for smallpox. So Canada, through the National Security Program, yes, a strategic stockpile, National Emergency Strategic Stockpile group has a tecovirimat, which is a antiviral that prevents the virus from leaving the cells or egressing from the cells, so thereby hopefully containing the virus replication to within the cells that are already infected. That's the biologic mechanism of how this antiviral is thought to work. But in terms of studying this medication in humans, there have been limited studies for smallpox or monkeypox. The emergency use is for smallpox, but that doesn't prohibit its use off-label for other orthopox viruses. And so in the current state, because the drug is not marketed yet, it does have a DIN or drug number, but it's not marketed by the company. So individuals and organizations cannot purchase this medication. We are relying currently on the NESS, the stockpile that has been allocated to various provinces, and I do not know what the allocation procedures were, but where I am practicing, we do have that medication, and I think other provinces have received their allocation as well. How that is distributed and in which conditions it's permitted to be used will be different depending on which province you're at. I think partly because this is still rapidly evolving. Some groups have developed interim guidelines on its use. And in British Columbia, the interim guidelines that we have largely follow the US CDC interim guidelines for treatment. In addition to tecovirimat, there is another antiviral, cidofovir or cidofovir, but that has also not been studied for its use in monkeypox in humans. And there is a scant sort of published literature on the efficacy on a case report basis of this medication. So it makes it very difficult to draw any conclusions on whether this medication is effective or not. However, we do have the product monographs of these medications, as well as some case reports on side effects, if any, are identified when used in humans.
I guess the limit on studies is that there just hasn't been smallpox outbreaks since eradication, and monkeypox outbreaks outside of endemic regions just hasn't happened. So I think they validated these, or at least tecovirimat on animals, I guess. And then
yeah, many animal studies, and then for human adverse events in terms of safety profile that has been studied in a limited number of humans as well.
There's no monkeypox specific vaccine?
There is no monkeypox specific vaccine. The vaccines that are available now are various generations of the smallpox vaccinia vaccine. And the one that we have access to in Canada, trade name is Imvamune. It is a vaccinia Ankara strain that is a live attenuated vaccine, but is replication deficient. So it's not capable of replicating like the second generation vaccinia vaccines.
So what's the difference between the two main smallpox vaccines, the ACAM 2000, which I think, stockpiled and frozen somewhere in a freezer and millions of doses are ready to give, versus I think Jynneos Imvamune, which I think expires pretty quickly, but it's like you mentioned, it doesn't replicate on its own. So it might be a lot safer to give. Like, what's the difference between ACAM 2000 and Jynneos? Why don't we just vaccinate everyone in Canada just to be safe if it's something we did 50 years ago, I guess?
Yeah, my understanding of the supply and the vaccines that we have, the ACAM is the second generation vaccine. So because it is a replication competent, that can lead to some of the severe side effects that we've seen before in specific populations. There are incidences of myocarditis, for example, but also in individuals that have underlying eczema, that vaccination can then trigger spread, so vaccinia spread more disseminated form in underlying individuals. So I think when it comes to mass vaccination, it's going to depend on risks versus benefits. At this point, there doesn't appear to be significant enough risk to take that approach. What people have done in the past looking at monkeypox outbreaks and smallpox outbreaks prior to eradication prior to eradication of smallpox is the ring vaccination strategy, where if the individuals who are identified as high-risk contacts are identified early on, they can be offered the vaccine. And what that time frame is for monkeypox is largely unknown. It's inferred. It's thought that if you can give the vaccine to the individuals who are exposed within 4 days of their last high-risk exposure, that should offer some protection, but up to 14 days. And so right now in Canada, the mechanism in Quebec, I think I saw that yesterday, or maybe 2 days ago, is that there is an escalation in their ring vaccination strategy to also offer it to people who have been identified in high-risk groups. So that would include people who have had multiple sex partners during the affected time frame. And so it is being offered by public health in Quebec to a larger group now. I believe they've vaccinated or given vaccinations to at least 500 people so far. And with the escalation in the strategy to try to contain this, I think many more people will be offered and hopefully receive the vaccine.
Is there any vaccine available for children at this point?
It's not I have to look into. I don't know if the immune for this is approved in children. I think it was limited to adults, but again, with all things in emergency use situations, prophylaxis, post-exposure prophylaxis, I think it could be used off-label on a case-by-case discussion.
I think the ACAM 2000, the one that used those funky bifurcated needles, the one that all of our parents have the scars on their shoulders.
Yeah, through that process of scarification to actually get the vaccine in multiple times using those needles, so that until you see bleeding after and a reaction after to suggest that there is take of the vaccine.
That's not going to be fun. Monkeypox has been around. It's recognized since the 50s or 60s. Outbreaks, there's endemic regions. Why is it spreading now? Why is it of great concern now?
There have been several different hypotheses. One thing that's certain is that with smallpox vaccination programs stopping at various times in different countries, a large proportion of the population will not have any immunity to smallpox, and therefore not have immunity to other orthopox viruses like monkeypox. So waning immunity or lack of vaccination is definitely one factor. In endemic areas where there is spreading, I think it's a combination of other problems, deforestation, climate change resulting in more potential for interaction with zoonotic reservoirs, as well as political instability and what's happening in the environment in the endemic countries is likely contributing to spread. Like this is in combination with things that will affect people's immunity, nutritional status, poverty, all those things.
Do you think any factor in the virus might have changed like we could have, previous SARS-CoV-2 infection or other factors like affect immunity, previous immunity that might have led to it spreading more? Is that a possibility?
It has been speculated as a possibility. It's not been discounted yet. However, based on the data they have from the genome sequencing of the virus and comparing it to the still limited number of strains that have been sequenced before and uploaded, this is a lineage, a direct kind of descendant of the previous viruses identified, and they do cluster. This multi-country outbreaks, at least for the strains that have been uploaded for comparison, do cluster on a lineage that is direct descendant but has mutations that are found. It's thought that the mutations are not significant based on, I guess, over totality of evidence, but I think there's still ongoing work that needs to be done from a genomics perspective to understand how this has evolved. I know that there was a publication a couple days ago on the website that hosts the different strains to be uploaded so that people can see openly where these isolates land. And in the next strain website under the monkeypox section, there have been a couple of isolates submitted in the US that do differ genetically from the European cluster or clade that's been found, and even from some of the isolates that have been submitted from the US, there's differences. So for example, the first case identified in Boston, that isolate does cluster closely with the lineage identified in Europe. However, there are two isolates, I believe, that do cluster differently, suggesting that there may be multiple outbreaks occurring. So although there is this one outbreak that we are aware of, involving a high proportion of what's thought to be sexual transmission, there's probably still ongoing importation from different areas, resulting in seeding of this virus in a non-endemic country. Even with the UK, the first report in the UK, I think it was May 6, that individual who was reported to have disease was a importation from Nigeria. There was travel associated to Nigeria, and the disease presented without further identified spread. So that was thought to be a dead-end transmission. And then the second incident in the UK, which was a household contact, did not have any linkages to the first case identified. And that second household cluster also did not result in any identifiable secondary transmission, either through travel or healthcare workers or other contacts. It was the third incident of cluster of 4 cases in individuals who identified as gay, bisexual, or men who have sex with men. That is the cluster that implicated through contact tracing to several larger scale events where there may have been lots of interaction with people. So through parties or festivals, that may have enabled spreading that way. So I think it's important that we still be aware of circumstances of importation or disease seeding that may be completely unrelated to the clusters transmitted through sexual contact.
Do you think, given how widespread cases, 900 plus cases on June 3rd, is there a potential pandemic potential? Could it be contained at this point? I know it's hard to speculate, obviously, but you're having unconnected cases from travel, especially on contact tracing. Is it possible that we can contain this?
So I think that is the area of concern. We don't know if we can contain this. Realistically, we know that there are efforts that can be done to contain this and eliminate it from countries that are seeing this for the first time. That requires a consolidated effort in all the countries that are seeing cases, and countries that are not seeing cases, they need to be prepared. They need to have active surveillance systems so that you don't have the potential for this to become endemic in a different location. Because I think if it does, it will have in the short term huge health impacts on the health system and on the individuals, given how long the infectivity period is. It does make it more difficult because of the long incubation period on one hand to contain, but that does also provide some benefit with the long incubation period to, if cases are identified early, then management of contacts appropriately, if given that time frame, may be able to help facilitate. So I guess there are factors of this virus that make it both easy to contain and difficult to contain at the same time, given what we're seeing now with the widespread.
There needs to be a muscular reaction to try to contain it. And I guess one thing is, like, in the pandemic, we saw certain countries did much better, like Japan, Taiwan, South Korea. Do you see strategies used in other countries for monkeypox that we think should be widespread, or set an example for other places? Or what would you do, based on example, what would you do right now to keep monkeypox from spreading in Vancouver, let's say?
Okay, so yeah, so in the province, I think that the important thing is to have a clearly communicated case surveillance definition. In BC, the website under the BC Centre for Disease Control is being dynamically kind of updated. People should look at that, and our healthcare providers for sure should look at that, use that as a reference for what are the surveillance definitions. By understanding the surveillance definitions, that will allow for identification of potential cases and the appropriate management after that. So having an aggressive, active surveillance system, especially when this is still new and our goal is to eliminate this, is essential. If we allow this to increase in case counts, it requires much more health resources, public health resources. And I don't think that with the health systems that we have now, we want to be taking that risk.
Do you see any lessons from our experience with SARS-CoV-2 and now, like what did we miss with SARS-CoV-2 that we can really seize the advantage now and try to prevent this?
Yeah, I think one of the things we learned with SARS-CoV-2 is initially the case definitions that were used in many places around the world were quite limited. It focused on travel to Wuhan. And we saw how quickly those case definitions became very insensitive in identifying cases. So I would hope that what we have as case definitions, and I think we have that now in British Columbia. I don't know about all the other provinces. There are some case definitions used in other countries that are more sensitive, but having a sensitive case definition that doesn't necessarily pinpoint the risk factors, epidemiologic risk factors that we know now. Of course, those are important to emphasize because that's where you're going to have the highest capture of cases. If you focus it on, or the specificity of the surveillance system, if you focus it on groups who are at the highest risk. But I think with the way we're seeing transmission and with this disease, what I would like to see is case definitions that are sensitive so that we don't take a narrow approach in only testing people that meet the highest risk. We have the capacity to do testing at this point, and capacity for testing can also be expanded so that it's not going to be a bottleneck or a major limitation in trying to contain this outbreak.
That's a really good point. I remember in the early phases of the pandemic when Italy was doing very badly, and I went to an official at my place where I work, said, "Why are we still screening people from Wuhan and China when people are literally collapsing in Italy right now?" I said, "No, we're sticking to the definition." So there has to be flexibility on these points. Do you know the status of the national stockpile when it comes to Jynneos or ACAM 2000, like the vaccines for smallpox and the antivirals? I know the Americans have millions of doses ready. Does Canada have a similar stockpile that you know of?
I think I've come across that in various places, but I don't have the numbers on.
Okay, that's fine.
Easily accessible right now. I know that it is thought to be limited. So the antiviral tecovirimat through the NESS, there is a limited supply because that was from the reserve. But my understanding is that there are plans to have the drug marketed either by the company or to have a availability that's going to be expanded. The mechanism of how that's expanded is not entirely clear at this point, but from what I've heard, it'll be towards the end of June that we'll have more information on the antiviral tecovirimat. In terms of the vaccines, we know that this was approved, or there was a contract signed, and that's publicly known from Health Canada with the company to supply X number of doses. How many doses that is, I think was, at least when it was published online, showed that it was for target delivery dates from, I think, 2023 till 2026. So I don't know what those exact numbers are in terms of purchased versus future allocation versus initiation of the procurement earlier on.
Hopefully sooner.
I think we'll be able to have more information from the Public Health Agency of Canada and their updates on the website. So
thank you so much, Dr. Leung, for joining us and providing this valuable information. And thank you for taking the time to talk to us and giving us a lot of important background information on this. So good luck. I hope you don't see it too often, and thank you so much.
Okay, thank you.
Bye.